We've had some new people join, and I just started the recording. So we're here with Dr. Hollon, Steve Hollon, professor at Vanderbilt and expert in cognitive behavioral therapy for depression. You spent your career doing research with many different things, but really, I think building the evidence base that cognitive behavioral therapy can be as effective, is effective in treating depression, but also comparing it to medication and kind of proving that, we don't necessarily need medication for everybody. We can use talk therapy to really help people through their problems and things like that and help them overcome the things that might be causing them to be depressed in the first place.
Quite fair. Yeah.
Great. So I guess, and again, people in the chat, feel free to throw out questions as they come up and things like that. Steve, what is depression? I know it's kind of a broad question, but yeah.
Yeah. Well, depression is it's the most of the work I've done has been on unipolar depression, which means these are folks who will have episodes of depression, which is usually marked by sadness, distress, often anhedonia, where they have difficulty experiencing pleasure. There's usually a collection of vegetative signs as well. They usually have difficulty sleeping, loss of appetite, loss of interest in sex, interest in things just generally goes down. People tend not to do as much as they would typically do. They don't expect to enjoy, so they don't try. And usually there's a decrease in functional capacity. People aren't operating as effectively as they typically would, although that's usually more a matter of a crisis of confidence. Not that somebody who's depressed can't do it, it's they don't think they can, so they don't start, or they give up too easily.
Interesting. So that's how someone can end up kind of laying in bed thinking that they're not going to enjoy anything, but interesting. And so I guess so I'm curious to talk about kind of interventions for depression, and maybe I can screen share and we can look at the kind of some of the theory behind, how depression is treated. But first, I'm curious, you've done a lot of thinking about the evolutionary component to depression and whether, well, one, can you talk about how many people get depressed, how common it is, and then why is it that so many people experience depression? Is it possible that it's not just a disorder?
Yeah, great question. Um, about 10 years ago, I started interacting with an evolutionary biologist, a fellow by the name of Paul Andrews. And it's an article of faith among evolutionary biologists that most of the things we think of as being psychiatric disorders that revolve around uh, negative affects, distress, things like anxiety, depression, etc., are not disorders at all. They're certainly not diseases. They think of them as evolved adaptations that served a function in our evolutionary past. Anxiety keeps you safe from harm, from risk. Anger helps you mobilize to face challenges. Pain is a good example there. Pain feels unpleasant, but it protects you from doing additional tissue damage. So it actually preserves. You look at NFL football players, people that get injured a lot and then will use painkillers and like to get themselves back out on the field. They often have great difficulty walking 20, 30 years later. So you see the protective function of pain. And the question is, if depression were an evolved adaptation, what role did it play? There are a number of different theories of that, but the one that I paid the most attention to is the one by Andrews and Thompson, which is what they call the analytical rumination hypothesis. If, for example, you look at somebody with an infection, they'll get something that's a lot like a depression. A lot of the same symptoms are there. And you look where the energy goes, and if you've got an infection, the energy goes to the immune system. It's energetically expensive, and you get sad, you don't want to do as much, et cetera, much like you would in a clinical depression. If you're starving, you have another depressive-like syndrome, and the energy doesn't go to recreation, it doesn't go to procreation, etc. Where it goes to maintenance of the vital organs, the brain, the heart, the liver, etc. When you get clinically depressed, the energy goes to the cortex, to the brain, and you have to ask, why is it going there? What's it doing? And basically what it does is it makes you think, and basically it makes you ruminate. And as a clinician, I've long ago trained, I would train others, that rumination is at best a symptom of depression, at worst something that might even deepen and make the depressions worse. And what the evolutionary biologists would point out is that when you start thinking long and hard about something that's a problem to you, it makes your brain resistant to distraction. It keeps you focused on the thing that's making you upset. And then there's a progression that it goes through from trying to sort out the causes for the difficulty onto what the solutions to the problem might be. And one thing we know about depression is virtually all episodes go away on their own given enough time. And this is actually a possible explanation as to why they go away. You think long, hard about the problem is, do you come up with a solution, and then when you solve the problem, the depression clears. So it's a very different perspective. Um, and if unipolar depression is not only the single most prevalent of the psychiatric quotes disorders, it's truly a disorder, but it it turns out it's a lot more common than we actually give it credit for, than we actually recognize. If you do retrospective epidemiological surveys, you think that depression shows up in about 15% of the population, 20% of women, 10% of men across the lifetime. If you follow something like the Dunedin sample, birth cohort followed from birth on, where you do ongoing prospective assessments, it turns out that the incidence of something that looks like depression is about 2 to 3 times higher than the psychiatric estimates make. And most of those are folks that are only going to have 1 or 2 episodes of depression in their lifetime, usually in response to something really big, bad, and major. Most folks don't have that many really awful, big, bad, major things. There's a smaller subset of people that have a lot of depressions, and they talk about them as being recurrence prone, but it looks like depression may be species typical. Anybody can get depressed if something bad enough happens. It doesn't happen that often to that larger proportion, but everything that I've been seeing last decade or so is converging on the notion that depression is an involved adaptation that facilitates thinking long and hard about complex social problems until you come up with a solution. And in that sense, it may be an evolved adaptation.
Interesting, interesting. And so, what does that mean? Well, two things. First, I just have a question about what you just mentioned about uh, that, there are big things that, most people could experience depression around. Like, what are some examples of that? And then what about the smaller things? Like, some people, could get depressed if they have a breakup, or does it require a death? Like, what kind of things are we
Yeah,
talking
yeah,
about
yeah.
here?
The big things would be things like a death. And historically, we don't consider a grief reaction to be a clinical depression, at least not until DSM 5 revised that, because we assume that's the kind of thing most people would experience. But in terms of the underlying neurobiology, it's virtually identical. It's essentially it's the same thing you get when you get depressed. Just we give people a pass on that. Someone like Jerome Wakefield would say that we ought to do the same thing with the loss of a job, major vocational reversals. There's some things which are big, bad things that would get anybody feeling sad and having a depressive syndrome, and most folks do. Um, there's a smaller subset of folks who probably come into adolescence uh, with a propensity to get depressed easily and to get depressed often. The people refer to them now as the recurrence prone, and it could well be innate. We certainly know there's some genetic propensity for depression. It could be acquired. Clinically, when I've worked with folks over the years with cognitive therapy, um, most folks who are prone to multiple recurrences of depression have core beliefs that either revolve around not being as competent as they think they ought to be or not being as lovable as they think they ought to be. It's either love or work. And those folks get depressed much more easily. It doesn't take as much to trigger.
Interesting, interesting. We actually got a question as well in the chat from Dr. Homer. They asked, how can you effectively identify depression with missed emotional labeling? So I guess that people can label themselves blindly. Maybe they're talking about if you're not realizing your own emotions or not realizing, like, how can, and Dr. Homer, feel free to respond to this as you hear it. There's a little bit of delay, just let you know, Steve. But how can we help people? How can someone effectively identify depression if they're not really able to detect their own emotions very
Yeah,
easily?
yeah. I would look at the rest of the syndrome. Again, I would look at are they have they lost interest in things? Have they stopped doing as much? Are they having difficulty with sleep, appetite, and interest in sex? For most folks, it's going to be insomnia and loss of appetite. For some folks, it's going to be hypersomnia and increase in almost kind of the munchies and interest in sex. But there's a classic syndrome in depression. And even if the individual himself or herself doesn't recognize the affective component, if you got the rest of it, then you probably got it.
Interesting, interesting. So affective component is in the kind of emotional experience of depression.
Yeah.
They might not recognize
One
that.
comment I'll make on that, again, from an evolutionary biological perspective, you expect anything that's involved adaptation to, what's the term? It ought to generate a whole body response. meaning it ought to organize the
Mm.
physiology, the affect, or talk about the affect, the cognition, the behavioral impulses, to respond in a way that was most adapted for our ancestors if they were given a certain kind of challenge. And if you get
Interesting.
threat, you're going to get something like anxiety, and if you've got loss or a complex social problem, you're going to get something akin to depression.
Interesting. So, you just mentioned something about, physiology, and we have, thoughts, behaviors, feelings, and physiology. So I think that's a really important, I mean, that's Aaron Beck, Tim, as he, as we call him, creating cognitive behavioral therapy, this model, this idea of how can we understand all these different experiences that people are having, that we, whether someone's depressed or guilty or feeling guilty or anxious, or they have an anxiety disorder, all these things can kind of be understood in some ways through, what you call the circle diagram. So I'm wondering if we could just briefly kind of go over that and show some folks. And I can just hold on one sec. I'm just going to screen share Help Club real fast. Hold on. Let's see if this works. Again, I'm new to Twitch streaming, everyone, so hopefully this will work. But yeah, so here we are. And Steve, I think can you see this as well, Steve?
I can, yes.
Great.
And
So, do you just want to kind of explain this model here, and how it relates to what you're
yeah,
talking about right now?
what that essentially is the cognitive model. It's the thing Tim Beck came up with. He was trained dynamically originally, and started his research career trying to test the Freudian notion that depression was anger turned inward. And what he went looking for was evidence of anger in the free associations, the dream contents of his patients. And what he got was the same stuff he would hear from his patients sitting across the desk talking with him. I'm inadequate, I'm incompetent, I'm unlovable. It was themes of debasement and inability. And after a while, he said, maybe I've got it wrong. Maybe there's nothing on the unconscious level that's the opposite of what we see in depression. Maybe what we got is people just believe that they're not competent and that they aren't going to get what they want out of life. So that's when he kind of flipped it and came up with the cognitive model. What the cognitive model would suggest in any given situation, and we may have that at the top where it says cognitive model, something happens. The way you interpret that situation, the cognition, is going to influence how you feel off to the right, and what you're going to do about it down at the bottom, the behaviors. We also added, Dennis Greenberg and Chris Podesky added physiology
Hmm.
about 15 years ago, and it's a nice addition because a lot of times it's hard for people to identify their affective experience. And if it's fear, if it's anxiety, they're going to be aroused. If it's depression, they're usually going to be a bit deflated. So it helps get you a little bit extra there. Now notice that this is a nice cognitive model. This Tim Beck came up with based on clinical observation, working with patients, etc. But it wholly fits the notion of evolved adaptation from an evolutionary biological perspective, because this is the whole body response, and
Mm.
you get a different whole body response if you've got a danger, a threat, imminent threat. You're going to be feel anxiety. You're going to have a desire to flee, to run away, to flee. Your physiology is going to be aroused, so that you can jump high, run fast. If it's a loss, you're going to feel sad, and you're going to have a kind of a de-arousal. It's going to be more less sympathetic, more parasympathetic, and the energy is going to go to the brain. So it's as if well, from an evolutionary perspective, you're going to have different challenges that are going to call for different responses in the part of the organism, and the evolutionary selective pressures are going to organize around different affects, so you get different whole body responses organized by that affect.
Interesting. So we also had a question. We have a couple other questions that have come up. So maybe we'll answer those questions, and then I'm curious for an example. Just for an example, and also if anyone in the chat wants to throw out an example of a friend or themselves of a situation in which someone has depression, just to note, just to be clear that this is not, what we're doing right now is not therapy, and this isn't a therapy session because we're just talking about the concepts. But as an example, it could be helpful. So if anyone wants to throw out an example, that would be great. But I guess we have another question that talks about the depression rates in teenagers in the United States, and the fact that these depression rates are kind of going up in teenagers. And so, are there any kind of theories about why the rates of depression are increasing amongst teenagers? I know also with suicide, we've also seen something similar to that. So, yeah, any thoughts there?
Yeah, and again, I'm no expert here, but I would look at social media. My wife is a developmental psychopathologist, and the biggest consumers of social media tend to be teenagers, particularly teenage girls. And the biggest thing that happens on social media is you have people ragging at you and giving you a hard time, and it's not a happy environment. It's easier.
Interesting.
You more bullies have more access to more people. So what do I know? But people get really wrapped up in that. In terms of suicide rates, again, um, they've been going down the rest of the world and going up in the States, and I got to wonder about the OxyContin. The
You say it again.
I got to wonder about the OxyContin, the opioid endemic that we've had.
And
If it,
and just
sorry,
specifically with for example, just for social media, how exactly how does that work exactly? Like, how does that lead someone to become depressed? Do you think?
well, I think you worry very much about what other people think about you, particularly if you're an adolescent. That's what adolescents do. And social media got a lot of access to people either snubbing you, saying bad things about you. And again, my wife's a developmental psychopathologist, and she was doing a study, intervention study with teenagers over the last year. And just hearing some of the concerns, they get very, particularly during the pandemic, they didn't have a lot of contact with people, but most of the contact came through the social media. And my goodness, how they lived and died for whether or not somebody liked them, responded to them, and
Yeah.
it's, a, it's junior high school on steroids.
Yeah, and it's also interesting because when we had the circle diagram, that model, which I can pop back up in a second. I just switched worlds here, but hold on 1 second. Let's see. Hope. Aha, there we go. Sorry, everyone on the stream. I'm just kind of getting used to this process. But when we have the circle diagram here, for example, like what are, I mean, for example, with the teenagers, it might be that their behavior is to go online and use social media. And then when they see other people who are posting who seem happier than they are, they might be thinking, oh, wow, my life is a lot worse compared to those people. And that might lead to feelings of depression, feeling sad, feeling guilt. Maybe, I guess, they can feel guilty or anxious even about their situations. And then the physiology might, they might experience kind of a shutdown or be very tired and things like that. So I guess that's an example of how these might interact with one another. And how would you help someone like that? Like, what is the idea of cognitive behavioral therapy? Like, we can understand our situations and take a step back and kind of understand how these things relate. But, how do we help someone with depression? Like, where does that actually come in?
Yeah. A couple things, a couple of points of entry. If you've got the physiology going, you can do things like meditation, exercise, a variety of things that can move the physiology in and of itself. If you've got the behavioral stuff going, most people treat their depressions like the flu. They take it to bed, which is the exact opposite of what you want to do. You want to get anything you would do if you weren't depressed, do it. Even when you're depressed, don't wait to feel like it. Just go ahead and start doing. That's the behavioral activation component. And on the beliefs, don't believe everything you think. Check it out. And there's some very explicit strategies we teach people about how to look for the evidence, look for alternative explanations, and look for the real implications. And it takes a little while to learn, but generally it's the kind of thing that you can learn, the skills you acquire, and usually within a couple of weeks, people get pretty good at that.
Interesting. So yeah, I mean, those are some of the tools that I think we've talked
Mm-hmm.
about in terms of, uh, like looking at the evidence for and against a thought, or
Yep.
kind of reframing questions, or what are the cognitive biases that someone might be interpreting their situation, how they're interpreting their situation and things like that. Some of these tools are ways that people can help take a step back from their situation and really see whether the thoughts that they're having that are related to their negative emotions are accurate or not. So that's
Yep.
really interesting. Um, yeah, and it's just incredible to think that Tim Aaron Beck came up with this. I mean, it's just I guess one other question, because we have a couple other questions in the chat, but one question for you is, how were things done before, like before CBT and before cognitive therapy? What was the approach to the kind of the majority of people? How were they approaching treating something like depression?
Yeah. In the 40s, 50s, the United States went very psychodynamic. A lot of folks came over after the
And
war.
what does that mean, psychodynamic?
Psychodynamic means that you assume that nothing is the way it seems. Everything is based on unconscious drives and motivations that got set down early in life, usually in the first 3 years of life. And then there are dynamic processes that keep you from being aware of what it is you really want, which is usually to kill your father and sleep with your mother, or flip that for women. And the primary form of treatment was long-term psychoanalysis, or at least a psychodynamically oriented psychotherapy. And you might spend years working on issues with somebody. Cognitive therapy, you're looking at 3 months, 4 months maybe for a typical client. And when I first went up to Philadelphia, East Coast, heavily psychodynamic place, two things. Number one, if I was serving as the project registrar for that trial, screening people into the trial, and I talk about comparing cognitive therapy to medications. We're going to treat you for 3 months. I'd say, 3 months, what can you do in 3 months? When I went away to my first job at University of Minnesota about 2 years later in the Midwest, where it wasn't so psychodynamic, I would do my next trial and I'd start screening people in, and then I'd say, well, it's going to be about 3 months of treatment. I'd say, 3 months? Why that long? You mean I have to come back? And so very different in the areas. When I was doing my apprenticeship with Tim Beck, and I went through the psychiatric residency program, and about halfway through the year, the associate director called me into his office. He said, Steve, we have a problem. And I said, what's the problem? He said, you're discharging your patients too fast. I said, but they're better. He said, no, they couldn't possibly be better. You're treating people, you're treating the symptoms, number one. Nobody ought to be doing that. You're just going to push them into a psychotic decompensation. And you're discharging people, 2-3 months of treatment. I said, well, that's all they needed. They're better. So there's been a real sea change in terms of what we now think we can do.
That's been, I mean, it's interesting what you're saying there, because anecdotally, that's very similar to what happened when I was seeing patients at Journey Pure in VR doing addiction treatment. I mean, when, I started the detox unit and seeing patients and taking them into, but it was really, I think, two things that were profound. One was the mood regulation that detox patients were experiencing just by going into virtual reality, putting on, I have a headset here, you put on the headset, you're like, you're looking around, you're in this other world and things like that. That was helping people alleviate negative emotions and increase positive emotions. But I think the most interesting thing was when we actually put them into a virtual reality environment and started trying to do, when I was doing cognitive behavioral therapy with them, I was putting them into environments like this one, and like completely different from reality, completely. Like they were in the rehab center and then they were in an environment like this, and you can kind of explore. Also, just to know, for anyone who's seeing this for the first time, like I'm an avatar. There's just I'm alone in this world right now, so there's nobody else in here. But you can explore the world and things like that. And we would go in here and do a CBT session. And what was interesting, I think, what you mentioned as well, is that we were seeing that people were picking up the concepts. Like when you present the circle diagram, part of, I think, you teach the CBT class at Vanderbilt and also do trainings all over the world. And in the first few sessions, the idea is to help people understand, teach people how to take a step back from their situation and understand, what are my thoughts, feelings, behaviors, and physiology in a situation, so that we can start to, examine the thoughts or change the behaviors. And we were seeing that after just a few sessions, people were picking that skill up, when typically it would take, several, 5-6 sessions of cognitive behavioral therapy in person to do that. So that's kind of interesting, that almost a similar anecdote of what you were just talking about. Yeah, go ahead.
I was going to say, it was so striking the first time Noah had me come out to Journey Pure and talk with a couple of the people he'd been working with in virtual reality, oftentimes just a single session or maybe two, how much they had picked up. Again, compared, it might take me a dozen sessions working with somebody to get them as far along as Noah's clients were describing having gotten on the basis of a session or two. It was just like night and day.
Yeah, it was really interesting. Also, I saw that someone offered to jump into VR, so you're welcome to come into the Fractal World 3. That's where I am right now. But yeah, okay, so we have a couple other questions that have come up. Also, Steve, we're about halfway through. I don't think I told you when this ends, but if it's okay, is it okay with you to go for an hour?
It has an ending.
Yes, actually, it's funny that you're saying that, because actually Twitch streams typically don't have an ending. They last for many hours. So, we have someone who came in. Hello, Tester.
Hey,
awesome. Are you watching the stream?
Sure am.
Awesome. Cool. Well, here we are. Welcome. So yeah, Tester's an avatar. I'm on my Mac my PC right now. But Tester's in VR, so it looks pretty cool. And yeah, so so I guess the question was, let's see, let me go to the question. So I think the next question that we had, and we have a question about what we were just talking about, but I'll just ask the next question first. Can thoughts really control our emotions, or do emotions control our thoughts? That's kind of
Oh,
like looking at, uh,
yeah. Yeah, in all fairness, both. If if something happens at work and I come home, my wife can say something really provocative, like "How was your day?" And if I come home angry, I'm more likely to interpret things in a way that's consistent with the anger. On the other hand, the way I interpret a situation is going to have a lot to do with how I feel about that situation. And so it again, these are whole body responses. You've got to think all of these things are going to feed in on one or the other. But it's if you're looking at places you can intervene, the easiest thing to change is behavior. The next easiest thing to change is a belief, and the toughest thing to change is the physiology or the affect. So it's useful to do a cognitive behavioral intervention where you're paying attention to the behaviors, you're paying attention to the beliefs, and that's going to move the affect, it's going to move the physiology.
interesting. And is there a difference between affect and feelings, or is that kind of like
I
similar?
use them interchangeably. Yeah.
Sure, sure. Okay. And then also with physiology, my experience treating patients with substance use disorder, I mean, physiology is just another way. Substances are a way to adjust our
Yes.
physiology. Putting heroin or alcohol, things like that, are changing our physiology, which then can change our thoughts or our feelings. Or sometimes decreases our inhibition so that we can, so that we go do things or whatever. If people are nervous about dancing at a club and things like that. So it's kind of interesting that even this model can explain so many different types of mental health
Mhm.
issues. And I think that's kind of, what's so beautiful about it is that not only can it help us create an intervention, but it can also actually help us understand
Yeah.
it's called, kind of the mechanisms or the ways that a disorder is actually occurring or happening.
Yeah.
Definitely. We have another question as well about what is the role of the beautiful VR settings in delivering effective treatments? Is it helpful or is it just pretty? And I'm curious, Steve, what your thoughts are on that. How do you think that these patients what do you think is leading, if let's say, and of course this is anecdotal, we've only done this with a few patients, we've had people in help club and seen this, so I don't want to say that we've proven this yet, but if it is the case that someone can acquire skills faster, more effectively within the environment, or learn the CBT kind of concepts, you know how do you think that's happening potentially?
I think it's the visuals. Again, I go back to the two young women that Noah had worked with very briefly, who were describing to me their experiences. And one of the young women was saying that her mother didn't come or something happened on a weekend visit she got upset about, and she visualized the circle diagram, and it was sitting in her memory bank. She went through the different stuff and it ended
This
up being very
diagram.
helpful to her. Yeah, that. And they say one picture's worth 1,000 words. I can talk with somebody for a while, but if they see something visually and if they got it in their memory banks, it's going to be much easier for them to use it. So who knows? But my hunch is that the fact that it's sufficiently different, it's distracting, it gets you out of yourself, and you have lovely visuals that you take away from it.
Interesting, yeah. And it's also interesting because whenever I demo virtual reality to someone, when they put on the headset, they go to the worlds, like we go into Fractal World 3 or the aquarium or other places. And when they take off the headset, as they're leaving our meeting or whatever, I ask, and this isn't therapy, but these are just kind of people I'm demoing or showing it to. I ask them, do you remember that aquarium that we were just in, or that Fractal World 3? Can you visualize that right now? Can you visualize that circle that I had in front of you? And they always say yes. And if I had drawn that on a white, and this is an experiment that needs to be done in terms of memory and recollection in VR compared to, I think, real life. But when we ask them, oh, how does it compare? That a lot of people speculate that they wouldn't have remembered if I had just drawn it on a whiteboard in front of them. So it seems to be very, very powerful that way. Um, Great. So another question that we have is, can you explain the concept of psychotic decomposition?
Compensation. Yeah, sure. Most folks do not have the capacity to become psychotic, but a small subset of folks do. We're looking at 2 to 3% of the population. We're talking about probably schizophrenia. We're talking about psychotic depression and or bipolar disorder. Two things. Number one, the disorders that can have a full-blown psychotic decompensation, as the term means, that the basic properties that we think of kind of fall apart. They decompensate. Yeah. Now, somebody who has the capacity to have a psychotic decompensation isn't typically psychotic all the time. Something stressors, something happens for them, but generally these are disorders / diseases. These are probably true diseases. These are probably breakdowns and involved adaptations, in which these particular disorders are highly heritable and not very prevalent.
And what do you mean by heritable?
Heritable means that strong genetic influences.
So people can pass it from their, people can pass it to their children potentially, or grandchildren.
And I would have said maybe even over a year ago that you probably don't have the capacity to have a psychotic decompensation unless you have the genes for it. Now beginning to think, particularly in the schizophrenia domain, this is probably a neurodevelopmental disorder, and there's some other ways that you can acquire schizophrenia without it being wholly genetic. For example, if your mother gets the flu in the middle trimester, the incidence of schizophrenia goes up, and that's probably extra genetic, no matter where the neurons go in early fetal development. But for most folks, it's going to be heavily genetic. It turns out that bipolar disorder, which the depressions are virtually identical to unipolar disorder.
And what's the difference in when you say bipolar?
Yeah, bipolar disorder, an individual has to have one or more hypomanic or manic episodes in their lifetime. And usually they're going to also have depressive episodes. They don't necessarily have to, but usually they do. And again, that's highly heritable. The coefficients there go up to about 0.8, about 80% of the variance. Autism is even more heritable. It's about 90%. Bipolar disorder, about 80%. Schizophrenia, about 70%. But low prevalence. So you're talking about 1 to 2% of the population, and that probably, if I were to guess, represents a disease which is truly a breakdown and involved adaptation. Whereas I would think of unipolar disorder as, with the possible exception of psychotic unipolar disorder, some do get that severe. There, I think it's probably more an involved adaptation. So I think the depressions you get in bipolar disorder look the same, but the underlying etiologies are probably just a bit different.
Interesting. Okay. Yeah, I mean, I think that makes sense. Yeah, it's fascinating how you mentioned just like a small thing, like realizing that, if a pregnant mother has the flu while pregnant, that could lead to an increased risk for schizophrenia. I mean, it's really, it's incredible to, and I'm in a class, the developmental psychopathology class, where we're talking about these things and reading articles from prominent researchers. And it's really incredible to learn how much we don't know about these things. And really, yeah, go ahead.
No, but let me let you finish, then I have a comment.
Well, really that the DSM, which is the way that we kind of diagnose these different types of things that we call disorders. I mean, really what you've talked about, like viewing it from a different perspective, where we've evolved to have all these different ways of reacting to our environment. And what we call disorders today is just our classification of behaviors and feelings that we don't think are appropriate for today's society. But that's such a radically different way of thinking than you have depression, you are a depressed person. It's very interesting.
Yeah, if they serve a function for our ancestors, they're going to be evolved adaptations. Doesn't mean they're going to still keep serving that same function, but odds are that they probably will. Take pain as an example. I mean, it's not, we don't usually think of that as an affect, but it is a distressing experience. People that are born without nociceptive pain receptors don't live as long. So it's uncomfortable, it's distressing, but it keeps you alive longer. And in that sense, it probably had an evolved adaptation. There's a classic, not a classic, but there's a study that I get a real kick out of. It's where I really started to make a conversion, where I'd start talking about being all about the squids and sea bass. A person named Crook and colleagues did a study. They were curious about the function of pain, and sea bass eat squid, and squid probably don't want to be eaten by sea bass. And what they did, took quartets of squids. 2 of them they didn't operate on. One of the ones they didn't operate on, they anesthetized as if they're going to operate, but didn't operate, and then another two squids didn't. They operated on, and they cut off one of the swimmers, whatever the squids use tentacles to swim and navigate. One under anesthesia, the other not. Then they put quartets of squids in a tank with a hungry sea bass and saw which one got eaten, most likely to be eaten. And if you didn't get operated on, weren't maimed, you were less likely to be eaten. That makes sense. But of the two that were operated on, the one that was operated on under anesthesia was more likely to be eaten than the one that was operated on without the anesthesia. And the difference was the one that was operated on without the anesthesia started evasive maneuvers, the kind of defensive maneuvers that squids engage, sooner. Somehow the pain was carrying information, and it altered its behavior. And the example there is that it may hurt, but it serves a function. It's going to keep you alive long enough to have offspring. And the basic sense among evolutionary biologists is that any of our typical non-psychotic syndromes that revolve around affective distress are probably evolved adaptations that kept our ancestors alive long enough to be our ancestors.
It's so incredible. I mean, I've told patients this, who have depression or anxiety, and I say, this is the things that kept your ancestors alive. Like, those are traits that you have within you, and your reaction to this situation, whether even if it's it's extreme social anxiety and things like that, and it's like, we can help, maybe use the cognitive model, we can examine your thoughts and kind of see what the evidence is that it's true or not true, or try new behaviors to help you get to a place where you want to be. But the fact that you are where you are now, it doesn't mean that there's something wrong with you necessarily. It just means that maybe these systems that kept your ancestors alive are just a little bit too active, or they're not quite fitting into the right situation right now. And, you see the relief of a patient, I think, when they hear that, and versus for years someone thinking only that they're deviant or, abnormal or things like that.
Yeah. Again, I think it's very much on target. If the something like the birth cohort studies are correct, or the studies of adolescents are correct, virtually any of us could get depressed, and it would take something bad to have it happen, loss of a loved one, loss of a job, etc. But virtually any could get depressed. There's a smaller subset of folks who get depressed probably more easily than they would like, and they tend to be recurrence prone. And those are usually folks that come into adolescence with some kind of propensity for getting depressed without that much happening to them. They're either innately acquired, or something happens in childhood. But those are things you can deal with too. The fact that you walk in the door with that doesn't mean you have to leave it there.
Yeah, fascinating. So I think in our last 15 minutes of the stream, also sorry to Twitch viewers who are used to 3-hour streams, but this is my first time streaming ever, so got to keep me into an hour. Also, Steve, obviously you're very busy. You just came from teaching a class and things like that, so plus publishing, all that stuff.
Classes.
2 classes, yeah. Plus all the research and everything else that you're doing. But I wanted to touch on, so we've screen shared a little bit of like Help Club. This is Help Club here and things like that. Oh, this is it looks like someone was exploring some tools. We have all these different tools here. It's funny. Sometimes I feel like I have to clean up. Like, I feel like it's messy and I need to, clean things up. But I'm curious, obviously Help Club is built on the idea of peer support, peer modeling, the idea that we can train non-professionals to provide some level of help, not therapy, because that's for therapists, obviously, to do therapy, but that some of these concepts, the tools that we've been talking about, are that people can teach these tools to each other. And I'm just curious if you could touch on some of the work you've done in India and some of that research suggesting, kind of what you've done there, with Vikram Patel and others, and kind of what it suggests.
Yeah. In the last couple of years, I've had the great good fortune of falling in with folks that work in global mental health. Vikram Patel, in particular, has done some really marvelous things. As a psychiatrist, was at the London School of Hygiene and Tropical Medicine, but founded an NGO called Sangat in India. It has multiple places in India where they operate. Vikram's now moved to the States. He's at Harvard now. And he's been, over the last decade or two, been working with very low resource settings in rural India. You just don't have much access to anything in terms of healthcare, much less mental health care. And what he's found he can do is train lay counselors to do pretty straightforward, reasonable behavioral interventions that get good results. And you don't necessarily have to have a professional. There's certain basic principles. If it's the pure behavioral stuff, the basic principle is don't wait to feel like it, do it. If you would have done it if you weren't depressed, go ahead and try to do it anyway. And if you bring in a cognitive component, it's basically don't believe everything you think. And it turns out that you can get some pretty good results out of things without relying on professional therapists.
So,
It's rocket science. Yeah.
so they found, I think it was that they were training high school graduates in India and training them in some of the basic concepts of cognitive behavioral therapy. It's a key concept, behavioral activation, that's typically done by therapists, which, can cost hundreds of dollars and things like that per session, or maybe covered by health insurance. And how was the efficacy compared to therapists?
Well, we don't know because they didn't have the direct comparison there, but they did
Okay.
get a nice reduction. It was compared. It was in primary care, so folks could get enhanced usual care in primary care, which meant we would let the treating physician know that the person was clinically depressed and give them some guidance in terms of if they're going to medicate, how they get medicated. Now, most of the folks didn't get medicated. Less than 5% did. They could have been, but they weren't. But we got greater change in the folks in this. This was a more purely behavioral, culturally adapted version of behavioral activation called the Healthy Activities program. But 6 to 8 sessions of this got some nice change with virtually no relapse. And again, I was blown away by the fact that we didn't get a lot of relapse in this population, in this setting. Many of these folks got better, and they stayed better, and that was just striking.
Wow.
What Vikram's working on now, he figures if he can do this in rural India, he ought to be able to do it in Texas. So he's bringing the projects back to the States, and he keeps working both sides of it. It's just amazing to watch this process unfold.
That's so exciting, and that's been a huge inspiration for what we're doing in Hope Club in terms of training facilitators, undergraduates at the universities, or people who are retired and want to help others, training them in the basic skills of active listening, and then some of the concepts of cognitive behavioral intervention. Making sure that everybody knows that it's not therapy, that they shouldn't replace typical treatment with it. Like, it's really important to say to people that this isn't a replacement for therapy, that there's a role for therapy, for medication, things like that. But if we can have something like what Vikram has done in India, and this idea of training, like, there's a lot of ordinary empathetic people out there who want to help others, and if we can teach them the key skills, some of the concepts that you've been talking about, don't believe everything you think. Even if someone could come into a experience and walk away realizing that maybe some of their thoughts aren't accurate, that can help them get out of something like social anxiety or depression.
It often can. David Clark, who, along with Vikram, I think is one of the premier healthcare researchers in the field, has developed a thing along with the healthcare economist Richard Laird in England called IAP, Increasing Access to Psychological Treatments. And about a decade ago, they went to the National Health Service and said, look, we have a lot more folks who are in need of psychological service than we have people to provide them. And we think we can set up a system that would save costs in the long run, take more people off of welfare, off of things, get people back to work, et cetera. And the government went ahead and funded. They invested £700 million in training people in these relatively straightforward interventions. They set it up as a step care system. So it might be a self-help program. It might be a guided self-help program. Folks initially, if that works, great. If not, you graduate on to something a little more intensive and involved. And they've raised overall recovery rates from about 35% over to over 50% in the last decade. They've hit all their marks, and things are much more accessible than they were in this country. Now medications have their role, and there's some folks that are just not going to respond to psychological interventions. But we are about 3 times more likely to medicate in this country than they are in a place like the United Kingdom, and the things that David Clark or Vikram Patel, those folks are going to be doing, look like they have long-term enduring effects that the medications just don't have.
Yeah, it's incredible. I mean, you've talked about some research, I think, that compares when you talk about enduring effects, you're talking about, I think we've mentioned this previously, but, the idea of relapse is that someone who has depression, might become better, and then they might get depressed again. They might be more able to get depressed in the future. And so this idea of preventing relapse, medication might, in the moment when you're taking it, help alleviate the symptoms, even though also it's fascinating that we don't fully know the mechanisms. There's competing hypotheses about even how that's working, which is fascinating. But then with therapy, it to me what's uh, just incredible about it is that teaching someone that they can take a step out of their situation and examine their thoughts or try new behaviors, the very simple concepts
Yeah.
can be more effective than psychopharmacological medications. It's just, to me, that's very profound that could be the case.
I mean, people do pick up skills. They learn how to do things. And the analogy I'll draw when I grew up in the Midwest, and you grew up in the Midwest, you have to learn how to drive on ice because the wintertime you can hit ice. And the natural human instinct, if you hit skids, is to steer away from the skid. What you want to do is steer the opposite direction.
Yeah.
And if the basic tendency of most folks when they get depressed is to do less, that's not going to get them over the depression. What you want them to do is do the things they would have done anyway, whether they feel like it or not. And that's not a hard principle to pick up.
Yeah.
If they learn to do that, then it helps.
And
And the basic notion is don't assume just because you think that you're inadequate and lovable, et cetera, that you are. Test it out.
yeah, I mean that's also one thing to note here, and I know that we're almost out of time here, but one thing to note that's interesting is that what really stuck with me, I've now TA'd for your depression class, I think 3 times, which has been, I mean, I've taken your CBT class, I think also 3 times, and I learned something new every time, so it's great. But I think what's interesting about depression that was really, surprising to me is that that depression is not about the fact that someone enjoys doing things less. It's really about a bias in their prediction of how much they're going to enjoy doing something. That's a pretty interesting distinction.
Depression tends to live in the expectation or the recollection. You can get somebody actually into a situation, they generally enjoy it more than they thought they would, or then they're going to remember it after the fact. So we do a lot of self-monitoring and a lot of just basically behavioral experiments with folks.
Yeah, fascinating. Well, there's so much more to talk about here, and maybe we can have you on in the future as well and to talk more, once I figure out my mic setup and turning off my Windows notifications that I've been pinging, I think, the whole time that we're on here. But so we have a couple comments. Oh, go ahead. Yeah.
No, I was going to say the only other thing is even if something's an evolved adaptation, doesn't mean you don't want to treat it.
Yeah.
It can be unpleasant, but I would pay attention to any intervention which facilitates what the adaptation evolved to serve. For example, solving complex problems, working things out. That's going to do better than simply anesthetizing the pain. And as much as useful medications can be if you have no other option, if you can learn things that serve you well, that move you along, resolving issues, complex social problems, etc., that's going to be so much better for you.
That makes complete sense. I've actually never heard you quite say it like that, and that makes, don't numb it,
It's all about the squids and the sea bass.
Yeah, fascinating. Well, we have someone who made a comment that in the chat that they are one of the people who's being trained as a helper, and that they have no background on the professional side of it or anything, and that they think it's better themselves to be able to be there for other people as well. So that's really cool. I mean, I experienced my own depression as a teenager when I realized that I was gay and I became depressed. And I know a lot of other people who have gone through depression who really are passionate about helping others. And you've also talked about, by the way, famous leaders like Abraham Lincoln or Winston Churchill who suffered from depression. So it's just, it's interesting that people, just because someone has a problem doesn't necessarily mean that, I don't know, they can help others as well, I think.
Nothing less about them. I have, and like you, I had my own experience with the depression. I had 3 depression successive years back in my early 20s. And once I started doing this therapy with patients, I've learned things I couldn't get depressed again, I don't think.
Yeah, it's incredible. And looks like we have one last question. Can depression be addictive like drugs and someone craves the depression and relapses?
It's interesting. I haven't thought of it quite that way. I'm trying to think of my experience. I've ever run into that. Not that I'm quite seen. And certainly the antidepressants, as far as I know, they're not addictive. There are other medication, other drugs that are. But certainly I think what happens is sometimes people can develop a kind of a self-concept around the notion of being depressed and having issues. So that sense, yeah, quite possibly.
Interesting. Huh. Well, yeah. Therapist, also, that another person commented, therapists need therapists, and it's definitely true. I mean, it's taking our own medicine and helping others. It's also, therapists have supervision to talk to other people to make sure that they're handling things the right way and everything. And yeah, so I guess Steve, thank you so much for coming on. I mean, there's so much more to touch. I think that we can touch on and things like that. But I'm really excited. This is our first ever stream. And also, I really admire the fact that, I'm pretty sure when I emailed you and asked, hey, would you be willing to come on my Twitch stream? You probably didn't know what Twitch was, but
No,
you
no.
said, sure, I'll do it.
I mean, I still don't know what it is.
Yes, I'll show you the video afterwards, and yeah, I really appreciate this. I'm very excited to kind of, I don't know, get a little more information about CBT out there to people, and help them learn about like what resources are available and things. And yeah, and if anyone has any questions or anything like that, feel free to email me, Noah at verywillhelp.com, or well, actually, I guess as our last thing, I can actually show you at the beach what this looks like. Eventually, I'm going to be very smooth at transitioning between these um, screens, but yeah, this is our website as well. So you can just, I'm pretty sure there's a pop up that will just have my name come up or something if you go to our website. But yeah, great. Well, Steve, thank you so much for coming on the stream. And give me one sec. If you hang out here for a second, I'm just going to stop the stream and then we can wrap up here. And thank you, everyone, for watching tonight. Really appreciate it. And yeah, this is just the beginning. So take care, everyone.